So cranial osteopathy was developed, or started to be developed, in 1899 by William Garner Sutherland. He was a student of A.T. Still, who developed osteopathy, and he happened to one day just be looking at what we call a disarticulated skull, a skull where all the plates have been separated, so it's just broken up into its constituent parts. And he realised when he looked at that, there was potential for movement in these. And so for the next 30 years, he really applied himself to developing what we know as cranial osteopathy. Cranial osteopathy is very much part of the profession of osteopathy. Initially, it was just called OCF, osteopathy in the cranial field. And then over the years, as there's been slight divisions in the profession, some people tend to be more structural in terms of massage, mobilization of the joints, whereas the cranial side of osteopathy is a lot more subtle, very gentle techniques based on 5 principles that Sutherland developed, of what he called the primary respiratory mechanism. The primary respiratory mechanism, he feels, relates to the nervous system. The nervous system has its own inherent movement, and the primary respiratory mechanism generates that movement. So it's responsible for the movement of cerebrospinal fluid within the nervous system, in the same way that the heart is responsible for movement of blood around the body. When we look at the primary respiratory mechanism within cranial osteopathy, there's 5 principles. One of the first principles is based on the movement of the cerebrospinal fluid. As there is a flexion and extension movement within the cranial system, we notice that there's a fluctuation in the cerebrospinal fluid, so it will move through the brain into the spinal cord, and there will be movement and flow through that system that you can gently palpate. The second principle of it that's involved is what's known as the reciprocal tension mechanism, and that is the relationship between the tissues in the brain based on the dura connections. So surrounding the nervous tissues, we have the dura. It attaches down onto the sacrum at the base of the back at the level of S2, and then it has a broad-based attachment onto the occiput as well. It also goes further up into the brain, and there's the falx across the middle of the brain here, and then the brain sitting on the tentorium. And when it talks about reciprocal tension mechanism, it means that if there's any torsion or pulling on one area will go tight and another will go slack. So you can actually palpate that because of the attachment points to the bones in the skull. So as a cranial osteopath's working, they'll be looking for that tension within the tissues to find that pull. So it's a really key component of anatomy, and it's a key component of our treatment, that we're looking for those kind of restrictions as we work. The third principle we look at is the motility of the neural tube. Again, the principle is that there's movement within the nervous system of the tissues, a flexion and extension movement within cranial osteopathy, and the peripheral respiratory mechanism is known as inhalation and exhalation. There's that kind of breathing movement, and there's a movement of the brain tissue, there's a movement of the nervous tissue, and that can obviously be impacted when we have different musculoskeletal injuries. The fourth point we look at is perhaps one of the more controversial ones that has been a sticking point for many regarding cranial osteopathy for a long time, and that's the mobility of the cranial bones. A cranial osteopath will look at the flexion and extension movements of the bones in the skull, in the midline, and in the outer bones, an internal, external rotation type movement. It's a very subtle movement, but that movement allows for the brain to move and expand as we breathe, for increased pressure from cerebrospinal fluid, and there's generally something that we'll look to palpate. It's very easy gently to palpate what we call the spheno-basilar movement, between the relationship between the occiput and the sphenoid, and you can feel a nice flexion extension movement and relationship between those bones when we palpate it. There's increasing evidence now that in science that this is a movement that does occur. Previously, most people, a lot of people in the medical profession have said it doesn't happen. By the age of 30, most of the bones in the skull are fused and they don't move. There's increasing evidence to that effect that they do move. The fifth principle is also the movement of the sacrum between the ilia, and the sacrum will have a nice flexion and extension movement, and in line with the movement of the occiput and the whole system as it moves into flexion and extension, or inhalation and exhalation. And we find that because there's that movement there, you can feel the tension between the two. So some treatments, you may be treating the neck, the head, but you're holding the sacrum because of that relationship and movement and flow of the fluids and the tissues between the two, between the occiput and the sacrum. So when we look at the treatments, you might come in with a problem here, but we might be treating elsewhere. So for example, you can palpate the cranial rhythm pretty much anywhere in the body. So I can treat patients, holding an arm, holding onto a shoulder. You can feel that inherent movement through the tissues. Because it's such a subtle treatment, often we're waiting for the body to tell us where there are restrictions, where we need to go to look for problems. So it's really a technique that uses a lot of light touch to really let people's bodies tell us what's wrong with them, and then to subtly adjust that. So when people come in for a cranial treatment, they're often surprised that all they're going to be asked to do after a detailed case history is taken is to lie and let me hold their head in a variety of different positions to try and work out where the restrictions are, where the tension is, to allow me then to apply osteopathic cranial techniques to improve their mobility and health. The best organisation in the UK for cranial treatment is the Sutherland Cranial Teaching Foundation, and they offer courses. They'll offer a 10-course package to become a fellow. I've done some of the training in that and will continue to do that through my osteopathic career. When I started training as an osteopath, cranial osteopathy was part of my training. So it was part of the package. I learned structural osteopathy, I learned cranial osteopathy, I learned visceral osteopathy, I learned a variety of other techniques to help patients. And I've then developed that because I realised some of the structural techniques left me unable to treat above the top of the neck. My treatments were limited by the upper cervicals, and I found that the subtle benefits of using a cranial treatment could really help patients that had maybe chronic pain, ongoing discomfort that made it very difficult to directly treat tissues that were painful. You could treat them from further away and get really good results, but you didn't actually aggravate the patient, because really most of the time as a cranial osteopath, I'm not looking at making big adjustments. I'm allowing somebody's body to work as I create a fulcrum for it to work around. So the patient's body is relaxing as I'm working. And that just takes an awful lot of time. You're continually learning about your palpation. We're talking about very, very fine movements, micromillimeters of movement. So it's a continual learning process, a continual education. For example, with some of the cranial techniques that I've learned, to train our hands, we'll put corks, half corks in pans of water, and then you have to try and touch the floating corks and not make them sink at all. So you have a very, very light, gentle touch, because some of the techniques, they may only require literally a gram of pressure. So it's a very gentle, subtle technique, which takes a bit of time to develop, but most osteopaths that have had the basic grounding in osteopathy, they understand the osteopathic principles, can then learn and apply cranial osteopathy in their practices. The type of patients that I tend to see for cranial treatments, I'm looking at the headaches and migraine type patients that have maybe had some other forms of treatment, maybe hands-on direct treatment, musculoskeletal, massage mobilization, and they haven't quite got the result that they wanted. They needed a little bit more, and then I feel that's when the cranial osteopathy side comes in. It gives me a little bit access to some deeper tissues in a very gentle way that can create some profound effects. Obviously, within cranial osteopathy at the moment, there's not a lot of very good research, so it's very difficult to say anything condition-based. I just use it on a lot of my patients for a variety of things. At the moment, for example, with a lot of people working from home in a very tight position, it's a nice way of unwinding the nervous system a bit. A lot of my patients are feeling a lot of stress, anxiety, they're uncomfortable at the moment and they're quite tense, so when you get into deep soft tissue, they're reacting to it, whereas a nice light treatment which allows them to relax, open up the nervous system a bit, can be very beneficial.